We're going to turn it over next to Esther for the session on how to address this information environment. Thank you all.
Thank you, Rachel, and welcome to our final formal panel discussion in this workshop, which will be really an extension, I think, of where our prior panel ended up. We'll be addressing the larger context of the information environment. My name is Esther Chernak. I'm an associate clinical professor at Drexel University's Dornsife School of Public Health and the Drexel College of Medicine, and I'll be the moderator for this session today. This morning, we've discussed a variety of topics: the translation and communication of science and the challenges of addressing myths and disinformation. In this session, we'll zoom out a bit, use a wider lens, and focus on how we communicate in the overall information environment today, the multiplicity of sources, the 24/7 information cycle, the overwhelming quantities of information of variable veracity and quality, and we'll examine strategies for addressing information overload during an emergency, especially when the science is uncertain or knowledge is evolving, or policy decisions are changing, as we encounter when a novel infectious disease emerges, but also in other disasters, as we heard this morning, including what the correct public health policy response is to wildfires. Our panel for this session features 5 speakers, all of whom have practical experience with crisis and risk communication during public health emergencies. They come from academia, from government agencies, at a range of levels, global, state, and local, and also professional media organizations, and they will share perspectives on communicating this in this information environment. I'll invite each speaker to share their remarks. Each will have approximately 5 minutes to speak, and then we'll have a question and answer period. If you'd like more information about the panelists, a link to their bios has been posted on the event webpage. And as in the other prior panel discussions, if you have a question, please put it in the Q&A window on the event website in Slido beneath the video player. Our first speaker is Dr. Lindsay Lininger, clinical professor at the Tuck School of Business, Dartmouth University. Lindsay, you have the floor.
Thanks so much. Matt's going to help with the slides. Thank you. My name is Lindsay Lininger. I am delighted to be here, really grateful for the opportunity. I've really enjoyed learning so much from everybody over the past day and a half. By way of background, I am a health policy professor at a business school here at Dartmouth, and I am a proud nerdy girl. And it's for the former moniker that I am here talking with you today, although the health policy and the business piece will come back at the end. So next slide, please. So perhaps you're asking, who are the nerdy girls and why are we here at the National Academies? About 2 years ago, I'm just going to tell a personal story. A little over 2 years ago, I was a Medicaid researcher, and indeed I've been a Medicaid or healthcare safety net researcher my whole career. And I was sort of between policy jobs. I had recently transitioned back to academia, and data were coming out from China and from Northern Italy. And like so many of us, we were trying to make sense of it, right? So I started writing about data on my personal Facebook page. Lo and behold, like so many of us at this conference here today, I was inundated with questions from my friends and family, and I quickly found a group of other women scientists and clinicians on Facebook who were similarly inundated with questions from their friends and family. So what we decided to do was to join together to answer these questions more efficiently on one evidence-based Facebook page that we called Dear Pandemic. Really in the spirit of the Dear Abby columns of yore. We took questions, we provided answers. Our audience grew beyond our friends and family, and by a magnitude we never could have envisioned. 2 years later, we now have 200,000 regular readers across social media channels. We've written over 2,000 evidence-based posts about the pandemic and pandemic-era living. We have involved over 36 women clinicians and scientists in the work. Our website's been selected for the Library of Congress's Digital Pandemic Archive. That's the screenshot you see top right. And we're really honored to have been featured at a promising crisis communication case study conference by the WHO. I think I'm most proud of the fact that we have gone from a public education campaign and we've transformed ourselves and built our way towards a sustainable nonprofit science translation platform. So we have nonprofit status. We are a nonprofit now. So in many ways, I feel like a founder, an entrepreneur, but just an educational one instead of a business one. Next slide, please. Okay, so why, what am I thinking about as I'm listening and learning from all of the proper experts here? I am new to crisis communication as of 2 years ago. I don't feel so new to it anymore, but one thing I'm puzzling through is, who the heck are the nerdy girls in the crisis and emergency response communication ecosystem? I am a proper nerd. I've done my due diligence. I have read, the logic models and all of the wonderful guidance that's out there by public health agencies, and we don't really fit. We are not an institution. We are not community health workers, although I am a former community health worker and I trained community health workers in my past, so they're near and dear to my heart. We are community ambassadors, I suppose. I'm just not quite sure. So next slide, please. There is some language that's emerging around who nerdy girls and others like us may be, and that's this term of micro-influencer. And perhaps that's right, although I'll admit that feels a touch weird. I feel it sort of sounds like a Kardashian, and although I respect the Kardashians for their business acumen and their entrepreneurship, that's not quite right. But I do think we as non-institutional actors, although we are an institution now as a nonprofit, I think we play an increasing role in public health communications. And indeed, we've heard notes of this throughout the talks earlier today. So my main obsession, final slide, please, going forward, what I have come to realize, being in a business school has been a stroke of luck, because I have some colleagues who have looked at what we've done and what we've built and said, you are a science translation platform. And like all technology platforms, you connect two sides together. And for us, we connect women scientists and clinicians with lay audiences so we can be in conversation with each other. And I believe that platform models such as ours are an important part of the public health communications infrastructure of the future. So I am obsessed with thinking about generalizing and scaling what we've built, and also empowering other nerds of all stripes to help join platforms of the future so that we can support emergencies, but also, quote unquote, public health peacetime when there's lots of other things and good messages to get out. So I don't have any answers right now. I just have stories and a real desire to help our public officials who've been on the front lines and learn from all the experts who are here today. Thank you so much.
Thank you, Lindsay. You've raised some really interesting points around trusted messengers and how to leverage that power, the power they have. And I'm sure we'll touch on those or pick up on those later in the session. Our next speaker is Dr. Supriya Barua. She is Team Lead, Science and Knowledge Translation for the World Health Organization. Supriya, you have the floor.
Thank you very much, Esther. And thank you for having me in the show. And thank you, Lindsay, for that. I take off from there. I'm Supriya Barua, as Esther said. I'm now the team lead for science and knowledge translation, but I started my career as a scientist, as a molecular biologist. I didn't last there very long because I preferred communication. I was briefly a journalist, but I've spent the last 15 years as a risk communication expert for public health emergencies in the WHO Southeast Asia region. So I've been in emergencies from the tsunami of 2004 to most recently the Cox's Bazar Rohingya crisis, and now, of course, the pandemic. So I've seen how communication has evolved, and we've talked a lot about digital media, which of course has changed everything. And and I've seen how we've had to change everything because of the influence of digital media. And that's a challenge in low-income countries where people may or may not be connected. You have countries like India and Indonesia where a lot of people have smartphones, but a lot of people don't. So how do you communicate with them? But to go on to what I'm doing currently at WHO, we're looking at science for communications in public health emergencies. Next slide, please. We've heard about taking science to the people, putting science in context. And indeed, at WHO, we are looking at what people are talking about in order to address their concerns. And you have questions like, what is long COVID syndrome? How dangerous is Omicron? To more strategic questions like, what are the testing strategies for COVID-19? Do I need to get tested? What are the symptoms? What are the different vaccines and why are they different? They're very specific questions. And as was mentioned in the previous session, over time, information changes and the answers change as well. And it does lead to a lot of uncertainty in people. Next slide, please. And we do know in times of uncertainty, as we've known from every emergency, people turn to those they trust. Next slide. But who do they trust? Well, recently, this is an Edelman Trust Barometer 2022. We find that employers are highly trusted, especially when people are feeling insecure. Community leaders are trusted because that's someone they know. And scientists are particularly trusted. In spite of all the bad press scientists have got recently, they appear to be trusted. So next slide, please. So what we're trying to do is, get people, reach out to the people, work with the people that communities trust and get them the information, get them the facts. If you look at this, the graph on the left-hand side of this thing, that's how much, by how much academic papers increased in the first year of the pandemic. There was just so much information. When we talk about giving facts to people to help them with uncertainty, there's just so much, forget the layperson, even policymakers at the national level, even public health people, it was impossible to keep up with all the information that's coming up. So what we've done is, try to summarize the key points, make it, simpler, accessible through various ways. One is what we call, we've established the network called the WHO Epidemic Information Network. We provide regular updates in the form of slide sets. The reason we put slide sets, which may sound a bit old-fashioned, is because, policymakers find it easier to use it. We have webinars. But most importantly, we engage the people who trust. So we've established 3 global networks with faith leaders, with employers, which we call Health in the World of Work, and in the Youth Council. Next slide, please. Next slide. So this is to give you an idea. No, before that, please go back. Yeah. To give you an idea of how the EpiWin updates are used, we send it across the world to all WHO offices. And then through our partners, through health clusters and ministries, it gets adapted locally so that it has the facts, but reflects the local context, and it's used in the local context. Next slide. Then, as I said, we had 3 global networks, one with faith leaders, interfaith leaders. We've had several dialogues with them, and particularly in engaging them in science and evidence and how they feel about it, because there's no one better to understand the community's concerns than the community leaders themselves. So what we've done is we worked with them to co-develop material based on scientific facts that will then reach which they will then distribute to the communities. Next slide, please. And with employers, this is an example of how we're working with the industry. I mean, we have a network of various employers. The tourism sector, as you know, has been very badly affected. They had a lot of concerns about safety of their workers. Yes, I'm just about to conclude. And so there was a series of consultations with mutual listening, discussion, collaborative design, and we've come out with one guidance for the accommodation set and the hotels, and the third on occupational safety and health in hotels, which was just recently published in January 2022. This is just to give you a snapshot of how reaching out to people who lead the different communities can make the difference, because they understand their communities, and we know the evidence, and if we work together, we can get the evidence and the information out in a way that that makes sense and is meaningful to them. Next slide, please. So looking ahead, we're expanding. We hope to have an EpiWin science translation network, because as I mentioned, scientists are among the most trusted, but everyone is involved in science translation, not just scientists, and we can all learn from each other. So we hope to involve media professionals, health professionals, and decision makers, both at the policy level as well as at the local level. Then we have other normative functions like documentation of good practices and having field guides, which we share so that the countries across the world and local communities can use those to go ahead and establish their own networks and have a cascading effect to get correct information. Next slide, please. Thank you very much. That's just a snapshot of what we've been doing and how we are taking the information to communities so that they understand it best in the way they know.
Thank you, Supriya. A really great model that seems to integrate so many of the good ideas that we've talked about this morning and in yesterday's session. We'll, I'm sure, expand on this discussion later in the panel. Our next speaker is Dr. Kimberly Henderson, Director of Communications and Community Relations, District of Columbia, Department of Health. Welcome, Kimberly.
Thank you. I would first like to thank the National Academies of Sciences, Engineering, and Medicine for this opportunity, and to the organizers of this event and session. No matter the type of emergency, a CBRNE, natural disaster, unintentional emergency, or pandemic, once an emergency is declared, an incident command system is activated, an emergency operations and joint information centers are stood up, and communicators begin to move into action. As communicators, there are a few things that we are confronted with and have to navigate in the process. Constantly changing and fast-paced information, battling misinformation and non-credible messengers, having small staff, if you have any additional at all, getting persons to change or adopt a habit or take action when they don't want to, and translating complex information into plain language while being culturally competent, just to name a few. So the question becomes, how do we get ourselves ready and prepared for navigating these situations? The first thing we should all have is a crisis communication plan that is updated on a consistent basis. This is a critical document to aid your agency and organization when a disaster occurs. It will help everyone who is needed for the communications aspect of a response know their roles and responsibilities. The plan should include guidance on how messages will be communicated, when information is needed, how information will be gathered quickly, what the communication pathways are to other agencies, and how public information materials will be released. While the next recommendation should be included in the comms plan and help guide it, as a communicator, you should be trained on and understand the 6 principles of the Crisis and Emergency Risk Communication, or Circ framework, developed by CDC. The framework is based on the premise that the right message at the right time from the right person can save lives. It's a framework that allows public health professionals in general and PIOs with a roadmap to deal with crisis and uncertainty without compromising the importance of timely public communication. Now, that is not to say that as communicators, we won't still experience some common pitfalls. There are things we must be on guard for because they can impede crisis communications, imperil a response, and compromise future trust of the constituents we serve. Some include mixed messages from multiple experts, information released late or not at all, overly paternalistic attitudes, not countering rumors and myths in real time, keeping internal conflict out of the eye of the public, spokespeople who exhibit a lack of appropriate emotion or use inappropriate humor, and overpromising outcomes. Now, to go along with the earlier recommendations, I want to share some of the strategies that we use here for all of our Joint Information Center activations in the District of Columbia, as well as a few tips and rules of thumb that I have applied as a public health and health communications lead. I live by a philosophy of meeting people where they are. And in order to achieve this, it's important to understand the audience, have a plan in place, and know how to reach residents. You should already know or have outlined what communication channels, strategies, or tactics are the best to reach each age group, as well as racial or ethnic groups, and vulnerable or at-risk populations within your jurisdictions. Then we must realize that one message does not fit all. To achieve this, once again, you must know your audiences and cultural differences. It's not always good to just translate words because words have meaning. So you want to convey the right message to all audiences, including those that may be limited English proficient or non-English proficient. Use culturally appropriate imagery or real people from the immediate community. If a person can see themselves in the imagery or have a level of trust in the person providing the message, it increases the chance that they will listen and take action, or at least think of taking action. During times of national disasters, localize the information as much as possible. It helps your audience know what this all means for them, and they, again, are likely to listen and take action. On a personal level, you should be in the rooms with leadership when plans are being made. Take notes that become the talking points on the issue. This helps to centralize messaging across your organization with spokespeople and keeps everyone up to date with the message. Have a cadre of trained spokespeople. If and when possible, always have a backup for the backup. And the last tip I will give is become embedded and be a part of your epidemiology and data teams. It's important that you understand what's going on because that's the only way you'll be able to inform others, even in a fast-paced information environment. And I'll stop here and I look forward to a robust discussion.
Thank you so much. What a fountain of wisdom you've shared. Lots to unpack there, and I look forward to continuing the conversation. Our next speaker is Dr. Ray Barashansky, my fellow Pennsylvanian. Ray is the former Deputy Secretary of Health Preparedness and Community Protection for the Pennsylvania Department of Health. Ray, the floor is yours.
Thank you so much. I hope you can hear me okay. Just give me some sort of sign. Perfect. So my first thanks goes to the National Academies for putting this on, but my second thanks goes to my fellow panel members today. Thank you so much. It will be difficult to follow you all. So exceptional. So states have a very unique role in communicating public health information, and several other panel members have stated that it's a core component of public health. And I'd also say it's a mandate of state health departments and health authorities to inform the public. It's a very interesting place to be sometimes as states work with both the federal government and local governments to assure that we're giving off a clear and consistent message. Pennsylvania, as you may know, is a very diverse state. We had much to communicate, and we have a lot of different cultural and demographic groups as well. So communication during public health emergencies is, much as many other panel members said, a very unique circumstance. Although we are looking at the broader context of COVID for most of our conversations today, it's very interesting because during various parts of our COVID crisis, we were also facing down another crisis, and that would be our overdose crisis in Pennsylvania, sometimes referred to as the opioid crisis. And it was kind of interesting going back and forth in communicating and finding effective ways to communicate in regard to both of these crises at the same time. I sometimes referred to our COVID crisis as the pot that boiled over extremely quickly, but at the same time, I referred to our opioid crisis as being on a low to medium boil at all times. And at the same time, we were seeing different biases in regard to how our public was looking at our crises and our public health emergencies at the same time. With COVID, the biases were sometimes around fluctuating guidance, whether that was in regard to testing, whether that was in regard to masking, or whether that was even in regard to vaccine. And with our opioid crisis, we were seeing a different bias or different biases. And sometimes that was related to, and this often occurred when we were speaking in public, people not understanding the crisis, people not understanding the government response to the crisis, and sometimes even leveling certain words that I don't like to use, such as the word junkie, which I was once asked while I was communicating with the press why we're quote unquote taking care of junkies. And so this was a very interesting back and forth as we looked at the COVID crisis, but we were also looking at our opioid crisis. And for those who don't know, in early 2018, Governor Tom Wolf declared the opioid crisis in Pennsylvania to be a disaster. That disaster declaration went on until literally about 6 months ago. So we were really in, for lack of a better term, double crisis mode or double disaster mode. And one of the things that we saw was that we really had to form a very well-informed communication strategy in regard to our opioid crisis, one that addressed stigma, one that addressed all that the state government was doing to address the opioid crisis. And then at the same time, what we saw was COVID was this strange, for lack of a better term, boiling point that showed us where public trust, the exact edge that public trust went to. And sometimes when we attempted to communicate, this became somewhat of a, for lack of a better term, combative environment as we looked to try to put forth crucial public health information. And I think the real lesson here is that public health is built upon public trust. We're not going to be able to move anything forward in regard to our public health initiatives unless the public trusts us. And one of the previous speakers showed a great slide. I wish I remembered who it was specifically. Please forgive me for not remembering specifically who it was, about who the most trusted people are. And I think that that is probably indicative of one of our big challenges in government. Government needs to be seen more as a trusted messenger. And therein lies the huge challenge. And as I look to wrap up and allow the next speaker to speak, I would say that we need some implementable best practices as government. Number one, we need to be clear and concise and not speak in government language. Yes, I just said that. Number two, we need to relay what we know, but also what we don't know and why we don't know it. Number three, we need to be open to questions. And therein also lies sometimes of what's seen as a weakness in regard to government. And last, but definitely not least, is understanding personal context, understanding the audience that we are speaking to. Different audiences want to hear different things from government in different ways. And the more we can address that, the better off our crisis communication will be. Thank you.
Thank you, Ray. Appreciate those remarks, and particularly for pointing out how we're talking a lot in this conference and workshop about the crisis of trust in public health, but it's really very much a crisis in authority and all government institutions and all authority figures. So I get more to discuss in a few minutes. Thank you. Our final speaker in this panel is Mr. David Olson, a reporter for Newsday. David, the floor is yours.
Great. Thank you first of all for the invitation from National Academies. I appreciate it. And so I obviously going to offer a bit of a different perspective as a reporter. And one of the things I want to start off talking about, I realize this is not just about COVID, about emergency preparedness in general. And I know one of the challenges, I think, for folks in the emergency preparedness field is getting stories, for example, about emergency preparedness in the long term into the media, because I think a lot of, for example, looking at climate change, for example, obviously that is a story that's often in the media, but I think a lot of Americans don't understand why they should be concerned about climate change because it's such a long-term type of issue. It's something so far in the future. And I think the same was true before COVID about preparing for pandemics. I think before COVID, people probably didn't really care about any type of emergency preparedness for pandemics because people didn't think it would affect them. Something like a tornado, warning that people will pay attention to if it's where they live because it's something that may affect them imminently. But I think for something in the long term, I think it's really important to try to convey to people how it could really affect their everyday lives. And I know that's a challenge I understand for things that are more in the long term. And in terms of COVID, one of the problems today, I think, is COVID fatigue and the fact that cases are relatively low. I know here in New York and in a number of other states, they're starting to rise again because of the subvariant. But on the other hand, I think a lot of people tend to read more or watch something on television more about COVID if the cases are higher, if there's a surge. And I know that that's one of the challenges for people in public health, is to try to get people to pay attention when there's not a surge, especially when people have heard that Omicron is, on the whole, less likely to lead to severe illness or death. I think it's important to remind people that even though that's the case, there's still a lot of people who died of COVID during the Omicron surge, and a lot of people who are hospitalized. And it's also important, I think, to remind people about long COVID. I think that doesn't get enough play. It's something I've written about, and other reporters obviously have written about, but I'm not sure if it gets enough attention, in the sense that I think if more people realized how relatively common long COVID is, even in a number of cases of people with a more mild initial infection, I think it could make a difference in how they approach both COVID as a whole, and also whether to get vaccinated or whether to get a booster, seeing that studies have shown that people who are vaccinated are less likely to get long COVID. And one other thing is speaking in everyday language is really important. I think that part of my job as a reporter is to condense and simplify what scientists and health professionals say. And, I like to use quotations in the story. And one thing to remember for a health professional or a scientist is that, a lot of our readers might not have even graduated high school. And a number of them who did graduate high school never graduated college. And even those who did graduate college or even have a graduate degree or doctorate may not actually have a lot of expertise in science. So I think it's always important to try to, when a scientist or health professional is talking with the media, to try to use everyday language that an average person could grasp, because I think that's really important in getting the public to pay attention to what's being said. And one thing is also important is acknowledging that you don't always have the answers important. I listened in on the previous session, and Dr. Osterholm made a good point that doctors and scientists haven't always explained well how science evolves. And I think that is the root of some of the distrust of scientists, is that I agree with him on that, in the sense that people hear, oh my gosh, I heard one thing one day, another thing another day. I'm not going to pay attention to these people anymore. And obviously science does evolve, especially on a new disease like COVID. And I think it's important just to acknowledge when talking with the media that, we don't always have all the answers. And maybe on this, we thought we knew that this was the case. We learned that was not the case, and try to just be frank with the public and explain that was, that's what occurred. In terms of deciding what to write about, obviously, like any reporter, I get a lot of pitches for stories and can never write about as many things as people approach me about. And one question I often, get from editors is, how does something connect with readers' lives? When a story idea I come up with gets rejected by an editor, a lot of times it's because editors think that readers won't care, or that it doesn't resonate with their lives. But on the other hand, I have to say, even though, like any publication, we want as many readers as possible, I know at Newsday, and I know at a lot of other publications, we will pursue stories if we think they're important enough, regardless of how many readers we might get, but it still has to be relevant in some sort of way. And I know I'm getting toward my time here, so one thing I'll add is also, as a local newspaper, and most readers do get their news from local news, is it's always it's always good to have some sort of local angle. I realize it's not always possible because there's not always localized sort of research. But for example, in terms of rising sea levels, I know my paper would be much more likely to cover something if there were a report, for example, that said that rising sea levels could destroy X number of homes on Long Island's coastline within X number of years versus a report that's more general about rising sea levels. And yeah, so bring it back to you. Thank you.
Thank you. Thanks very much, David. That was great. And I think a really interesting perspective to have on our panel. So we have some time for questions. I welcome the questions from the audience. Please feel free to post them in the event website. Question, there's a lot to unpack. And one of the things I think you all raised was, the complexity of public crisis communication plan or what public health communications is. And, we talked earlier in the day about the need to fund public health communications, but I suspect the people who fund this work, certainly in government, don't really understand what that means. They probably think it's setting a spokesperson for media training. And yet you all spoke very eloquently and in great detail about the need to be in the room with the CEOs and the leaders who make the policy decisions, so you understand why they're being made, to have access to the data so that you can explain it coherently and ideally succinctly. What are your thoughts about how to represent that, and just what's involved in optimal public health crisis communications? And I welcome comments from any of our panelists. Lindsay, did you want to?
I will happily. So I guess I would urge people, again, there was a comments about meaning making, and I'm still trying to make some meaning out of what has happened to all of our lives as crisis communicators, as people. But one thought that springs to mind as a brainstorm, if not like a policy solution, is to think outside of the public health emergency response box. So I am in a business school. I'm a health policy person, right? I've spent my whole life in health policy, but I've gotten more help from my business school colleagues in doing this work than I ever could have imagined. So my social marketing colleague helped me with messages. Had an opportunity to speak with the Chamber of Commerce. We have a platform. I always bring props to my class or my talk. This is called the Platform Revolution. This is about evidence-based technological platform design, right? And that's a business school professor. And I have a close colleague here who is a strategist, and he runs what's called ecosystem strategy, which is aligning partners when traditional institutions don't exist, which is like our current information ecosystem, right? Aligning non-institutional players. So I think all of us are embedded not only in our public health networks, but also other places that, can support us. And I found that my business school colleagues have helped me so much. And similarly, hearing David's remarks, we had some really wonderful press training and journalists who came and have helped us and have coached us. So I do think building those bridges outside of public health might help.
Thank you. Supriya, you have your hand up.
Thanks, Esther. I'd just like to take what Lindsay said forward. In our networks, we have very different groups that we work with. One is on faith leaders, the others on employers. And what we've learned is it's really been a very, I think, humbling experience working with them. The perspectives are very, very different, and that enriches how we look at the pandemic as well as public health professionals, and really this, not just the perspective, but also the skills that they bring help us work better across in our messaging, not just with that group. So it has an impact far beyond just a limited sort of interaction with one group.
Thank you. Ray, did you want to add to that?
Just really briefly, I agreed with something Lindsay just said about the public health training, the public health communications training. I distinctly recall some of my early communications training where, and this might be an implementable best practice, where we were yelled at repeatedly by our PIO to see how we would react. And eventually you got to a place where I see Dr. Henderson shaking her head. You feel my pain. And eventually we got to a place where being yelled at by people when we were on the podium wasn't really a shock. And years later, it had been a while since I'd been yelled at, but years later I was yelled at during another press conference, and it brought me back to that initial training. But secondarily, and of no less importance to that one, is the having backup. And I believe it was Dr. Henderson who said that before, but I could be mistaken, whereupon no one person should only be in the position of communicating, because there's going to be a time where you're going to need somebody else. And so as we look at implementable best practices, those are two that maybe we should cling to a little bit more.
Thank you. Yeah, a lot of great best practices here. One of the things that struck me was all of the efforts to really ensure bidirectional communication and to really understand the audiences. And I was struck by Dr. Henderson's description, the every 6-month survey. They need to understand what's happening in their public, and it completely drives their public information response. Something that probably most people wouldn't think is a necessary part of public communication. I wonder if anyone could expand more on that, the bidirectionality and the value of that, and what the optimal approaches are to that, and how do we convince our funders and our taxpayers to fund that? Dr. Henderson, maybe you could chat. Yeah, go ahead.
Sure. I wasn't sure how we were. A couple of things that have been implemented here. One is that we are using social listening as a component of helping us to develop our messages. It's important for us to understand what our residents or what people are actually saying about various health issues. What are their concerns? What are the questions that they have? What don't they know? What don't they feel like they're not getting? And in order to understand that, we're not just doing monitoring of social media, we're listening on there. So listening without them knowing that we're actually listening to them in that particular manner. And what we do, and what I have encouraged my team to do, is to develop communication plans around that. That's how we develop our communication messages now in an environment where we've just been messaging constantly over and over again about a lot of different things. Now that we understand what they need, we can get directly to the point. Another aspect is actually going to the community. I tell a lot of people all the time, I know sometimes how to communicate with somebody who's 65 plus. I have a mom who's over 65. So I understand how to communicate with her and how to get to that particular audience. I can communicate in some ways with persons who are in my own age group, because I understand what we like, what we do, how we talk, how we speak, all those different things, even across the cultural different spectrums. I understand that. But when it came time to talking to youth and young adults, I was like, okay, I'm over it. I'm done. This is not me. I cannot do this without talking to them. So utilizing those advisory groups that we already have within the health department. We have youth advisory groups within our community health administration, within our HIV/AIDS administration, asking them specifically, so what do you want to know? Why are you not, taking action? What is wrong? How can we communicate with you? And the one thing that they told us, they didn't want us to change the information. They wanted the information, but they wanted people who look like them, bringing in students from the medical school to talk to them because they're more along the lines of their age, but then speak directly to them. They feel as though the messages were speaking to their parents. So once you understand how people want to be communicated with, what they want to know, you can actually create those messages that will resonate with them. And so those are two methods that we have used here.
Thank you. Does anyone else want to add to that? Lindsay.
Yeah, so we, just out of dumb luck, I'm not going to lie, we are a bidirectional, we are a conversation, right? And when I talk about the Nerdy Girls, we are a platform that connects women scientists and clinicians with lay audiences to be in conversation. And that was probably the best bit of dumb luck that we had at the beginning, because just by this, we have a question box. I mean, literally, like it's not fancy infovalence. It's like a question box. And we just answer questions. And because of this rapport and because of this conversation, I don't feel like the stakes are so high if we get a message wrong, or if I'm not as worried about sort of message crafting, because we have this kind of conversation and we say, hey, science is a method, not a fixed set of facts. Our answer might be different, right? So I think stressing that this is a conversation as opposed to like, I have to craft this perfect risk message, helps reduce fear for people like me who want to get into the game as scientists, but don't have all the wonderful training and experience of a Dr. Henderson, right? Or we're not journalists by training, but we can have conversations, and you can actually blow up a network just by being in conversation.
Thank you. So perhaps related to this topic, I think, there are many times where in public health, the news isn't always good to share. Maybe you're concerned about the reaction you're going to get. And I think one of the questions that arises is the so-called reverse trust question, which is, can public health find ways to trust the public with more of the truth? And I'm interested in knowing the panelists' thought about that when the truth is difficult or complicated and maybe won't be received well.
Yeah, I think it's a difficult question because I do think, again, one of the issues is that with the evolving knowledge of COVID, that's caused some of the distrust. But on the other hand, there's that concern, I'm assuming, of if you're really frank with the public about, for example, some of the, I wouldn't say deficiencies of the vaccine, but the fact that the vaccine is not as perhaps as effective as, especially with Omicron, as once thought, I know there's that risk of people thinking, well, why get vaccinated at all? And so I know it's a really difficult balancing act between being as honest as possible and wanting to keep that trust. But on the other hand, because one of the issues is I try to remind myself as well as a journalist is that, most people have a lot of things going on in their lives. They're not going to, sometimes people ask me, well, why would someone not get vaccinated or get the booster with all of this, blah, blah, this, and this? And the reality is most people, I'd love to say people read all my stories, start to finish, but most people, if they read my stories, typically probably won't read the whole story. And to be honest, more people probably get their news from Facebook or Instagram or from a little 20 seconds report on television or radio than they will reading in a newspaper. And so that's one thing I think public health officials need to also, and I'm sure most of you do realize that, is that the public there's so many things going on, and most people are not going to spend a lot of time doing research or spending a lot of time listening to what all the scientific data says about something.
Thank you. Does anyone want to add to that? Go ahead, Ray.
David, that was a great point about people having so many things going on and potentially even getting, let's just say, their public health information from Twitter. Are we safe with that? But at the same time, I think we have to address the fact that we're living with the most informed populace ever. So they're getting a ton of information. It reminds me of an old commercial of where the plumber or the person working on the house said that you're going to need this really strange part and it'll be $300. And the person goes online and says, you mean the $3 part? It's the same thing. We have to be the bearers of the best information possible. And Esther, your question is a great question. It's really tough. We are sometimes the bearers of bad public health news. And I think this kind of goes back to our previous point, and Lindsay did a great job with it. And so did Dr. Henderson, in that we need to train our people for the good and the bad. We need to train our people to be public health communicators of public health bad news. And it's going to end up happening. We saw it during COVID. And we need to build on that. We need to build on the fact that occasionally, or sometimes more than occasionally, we're going to have to give bad public health news to our audiences.
Thank you. Yeah, I think that's one of the biggest challenges, especially when I think, particularly at the local and state level, but I guess at all levels of government, public health is in the crossfire a little bit. And we're often accused of mishandling things, not reacting quickly enough. And I think how those of you who've worked on this front line, how do you separate the bad news and convey it in a way that doesn't invite criticism for your agency? Because I think that's often the one of the things that folks are very reluctant to address. So much of what's bad news is considered a failure on the part of a public health department, when in fact it's not. How do you navigate through that confusion? People are always looking for a scapegoat or someone to blame. Dr. Henderson.
Esther, I would just say, first and foremost, you have to be honest and you have to show empathy. When you're honest and you're showing empathy, people understand that, you're not saying something because you're just saying it, or because you want them to take action, or because you don't care. And you have to let them know that you're a human just like they are, and how this will impact you and your family as well. Just so bringing in that personable piece also helps. And I'll just say, point and blank, the first time that I had to announce the first death due to COVID, it took me a minute. Even writing a press release, it took me a minute, because I had to realize that it was real, and that this could actually happen. So it's understanding how a person would feel, knowing the tone to use, being honest, being empathetic, and being personable, and bringing it. In some ways, we use those storytelling techniques, but you really have to emphasize those particular strategies and techniques for people to actually listen and understand that, it's not you. We know it's bad news. We know you don't like it. We know it may hurt, but we're all experiencing the same thing at the same time and together.
Thank you. Other thoughts or comments? I see some folks nodding. Ray, your hand's still up. I'm not sure if it's from the last round or whether you have something to add to this conversation.
No, that's from the last round. I'll take it down.
Thanks. One of the things that's come up is, this information fatigue that we're all living through. This has been a story in the news for the last 2 years. There's only so many new variations, new iterations that you can share. How do you keep it in the news? How do you tell people what might be health protective and what they need to know when they're not as interested and may not be paying as close attention? How have each of you struggled with that one? Lindsay, you're nodding. Did you want to say something?
I will say something, and again, I'm not sure if this is necessarily a best practice from an official standpoint, but from those of us who are non-institutional communicators, we from the get-go have had a mental health beat at Dear Pandemic. We have psychiatric nurse practitioners who are nerdy girls, and I think that content is pretty evergreen and always needed. We also mix in celebrations of women in STEM. And, we tell stories that aren't just about COVID. And I think that that's going to be important as we go on. I know, public health officials, institutional communications are different, but I do think it's been important that we have attended to the whole person of our audience. And I think that has helped us kind of ride the epidemic curves of information, if you will, right? Because our engagement metrics go like this with the epidemic curve. So we've had to learn to ride the waves and sort of learn to make the most of when we're down, because that lets us trial new types of information and new types of communication techniques and build trust around different issues.
Thank you. Supriya, did you want to add to that?
Thanks, Esther. What I wanted to say is, if then there's an information fatigue, listening to people's concerns and what really they want to know is key. And at an institutional level, we do that too. As Dr. Henderson also said, we listen to the social media posts, questions that are being posted there, as well as through our networks, get a sense of what people are concerned about, and then frame the information based on what those concerns are more likely to resonate than just providing the information. As Lindsay earlier said as well, the power of personal connect, it's framing it in that context to make a difference.
Thank you. Here, a question about the time frame of the scientific process. Most of you are aware that science takes time, that one study doesn't provide all the right answers for every public health issue or question. What are your thoughts about how we might address the science to action timeframe with the need for immediate and trustworthy information, particularly at the hyperlocal level? What are your thoughts about how to navigate that challenge? And I'm maybe perhaps as you think about your answers, many of you talked about ways in which you educate the key trusted intermediaries. But obviously that can't happen immediately with some of the scientific studies that need to happen to figure out what to do. So thoughts about that, the glacial timeframe of science and the hyper rapid information cycles in which we live. David, were you going to say something?
Yeah, well, actually, I think part of it, and this actually even goes to the last question as well. I think part of it is also just beyond the actual studies, is also just humanizing. Like, for example, long COVID, there's still a lot that's unknown about long COVID. There's some general idea of the prevalence of long COVID, although less so among kids. But one of the things I've done in every story I've written about long COVID is I always have had 3 or 4 people who actually have long COVID to explain what's going on with them, talk with doctors and experts, and include the fact that a lot is still not done, a lot is still unknown. There are still obviously studies going on, and studies sometimes have different findings. That's one thing, obviously, and that's not just true with long COVID. With a lot of with diseases in general, obviously there are sometimes contradictory findings, but different findings. But I know for me at least, as a reporter, and I think this is helpful for public health professionals as well, it's also just important beyond the studies is to also humanize what's happening and the effects, in this case, of long COVID, or for that matter, just to remind people that people can, still, even with Omicron, still die of COVID, to actually tell those stories of people who died of, I went to a hospital several weeks ago during the Omicron surge here in New York, and there was a really sad story of someone who's, I think it was a man, and his son and daughter were arguing over whether he should get vaccinated. I believe it was the daughter who did not want him to get vaccinated. He didn't get vaccinated and ended up dying. And, it's a horrible story, but it's also that I think that really hits home for readers as to how that decision not to get vaccinated may have been the reason the man died. So I think those human stories are really important.
Thank you. Other thoughts or comments?
Yeah, I'm not really sure I could follow that with anything, David. That was amazingly emotional and visceral. But I think that reiterating the lessons that no one study tells the whole story, reiterating the lesson that science takes time, and then the personalization of what we're seeing, and even taking it back to other public health emergencies and other public health, even diseases, viruses we've seen in the past, and how we moved out of that. So I think those are some of the areas where we've tried to really bring forth the message, the science takes time, no one study tells the whole story, and then that intense personalization of what we're seeing out there in totality.
Thank you. Additional comments or thoughts? We have about 2 to 3 minutes left. Go ahead, Lindsay.
I have a comment, and I'd be curious to hear if it lands with the wonderful officials with me. I have heard a lot of talk over the past day and a half about social media, digital media versus more traditional community-based models. And I just want to put it out there. What I've found in this work is that it's both. I mean, we're digital first, but we've done a ton of community education events, and there's so much spillovers. So I just hope the message that, like, in these new information networks and environments, is that it's both and. And, indeed, sort of the honorific that touches my heart the most as a nerdy girl is we got a Philadelphia Citizen of the Year award, right? And that's a place-based community, that even though we're digital first. So I just think as we're talking about addressing the new information environment, we know that there's spillovers, and it's really a both and.
Congratulations, first and foremost. Philly's a tough city.
You would know.
I would know. Additional thoughts or comments on just the information environment, the pace of science, as we conclude this panel? Okay, well, I'd like to again thank everyone on this excellent panel for their remarks, and thanks to all of you for your questions.